così, huh?
Hello.
What smell?
Petrol or something.
Hello.
Yes, sir.
Dr. Vijay, we can hear you. We can hear you. Okay. So we'll start now.
They can hear you. So
We can hear you. Okay. We can hear you.
Okay.
Fine. So very warm welcome to all of you for the third grand rounds. The idea of this grand rounds that we do every month. Okay, it is going to be fixed. The last Friday of every month, same time, 8:30 onwards, we will be starting this grand rounds. Okay. The aim of the agenda, how the grand round goes, is that one of our colleagues, okay, from anywhere across the globe, it can be, will be presenting a patient, one or two patients, okay, we are going to present, and based on which there are going to be some questions. We are going to provide the basic information that is required to understand that presentation. Okay, if threadbare is required, threadbare we will present. Post which we will have an eminent panelist, one or two eminent panelists, who will be taking questions which are raised by the case presenter himself. Okay, and trying to answer the unknowns. Okay, try to make sense of what is unknown. This is the plan. So with that we proceed. Today it is my proud privilege to present to you the presenter and the panelist. Abhishek, please take care of the waiting room. Okay. Okay. I hope you are able to see my screen. Okay. So the panelist, the case presenter for today is Dr. Vijay Vishwanath Guge. Okay. He is a senior consultant in neurology from Nashik. Okay. He completed his DM Neurology from Maulana Azad Medical College and GB Pant Institute of Postgraduate Medical Education and Research. He has a special interest in vertigo, movement disorders, headache, Botox and acute stroke management. He has publications in a variety of fields and interests, some of them in lacunar syndromes, clinico-anatomical correlations in aphasia, gluten sensitivity as a cause of reversible cerebellar issues, and also some movement disorders, and also writer's cramp in spinocerebellar ataxias. So he has that wide variety of interests, and more than that, he is a man who is readily available for calls for any doubts. Okay, and he keeps helping ENT surgeons from across the country in trying to solve their neurological queries when it comes to their vertigo patients. Now, the panelist for today is Dr. N. Balamurugan. He did his DM Neurology from NIMHANS, Bangalore. He's conducted a movement disorders workshop in August 2018. He has more than 100 guest lectures on a variety of topics in neurology across the globe. He's contributed chapters to 9 books. He himself has authored 3 books in Tamil language on headache, Parkinson's, and epilepsy. Over 50 publications at last count, it must have been crossed a little more, of which over 30 are in PubMed Index journals. He is involved in a lot of community activities. He has a trust for muscular dystrophy. Okay, he always is very active in creating public awareness through pamphlets. He made sure that the police personnel, among them, the self-monitoring of BP is begun by increasing awareness and also by distributing the BP apparatus among them. He is known for several firsts in neurology in Salem districts, including for deep brain stimulation. And then he has membership in a variety of very highly regarded societies. Okay, best paper award. Okay, in our Diamond Econ 2005. Okay. Then Ibrahim Bailem Oration for Tropical Medicine in 2011, Fellow of the Indian College of Physicians 2015, Fellow of the Royal College of Physicians 2019, Fellow of the American College of Physicians 2021, awarded Teacher Par Excellence Award, South Zone Epicon and Tapicon 2021. Okay. This count of more than 25 publications is an old count. Now I've just seen, and it is more than 50. Okay, and more than 100 lectures. Now the latest count is more than 120. Okay, he's finished in a lot of. He is the go-to man for a lot of people in different topics in neurology. Currently, he's working as the director and consultant neurologist, SIMS Chellam Hospital, Salem, Tamil Nadu. Okay, so with this, I welcome both Dr. Vijay Guge and Dr. N. Balamurugan to this conference, to this Grand Rounds presentation. And in addition to that, I also welcome all of you for joining here directly on Zoom link, and those people who are watching it on our YouTube live. So welcome all of you. So before we actually start off with the case presentation, I would like to give a brief overview. Today's case relates to today's cases actually relate to the dalfampyridine, which is a 4-aminopyridine responsive vertigo. So that is supposed to work on Parkinson. That is supposed to work on the pyramidal cells of the cerebellum. So I thought I'll just give a brief overview of the cerebellum and its relation to the vestibular system before we actually have the presentation. Post the presentation, okay, Dr. Vijay will be raising some questions, and all of us together, or with Dr. Balamurugan, will be trying to answer them. Okay, the vestibular system is the only sensory system whose primary afferents make direct projections to the cerebellum, not vision, not taste, okay, not touch. None of these sensory organs make direct projections to the cerebellum. It is the only the vestibular system, the only sensory system whose primary afferents make direct projections to the cerebellum. Okay, when you see the cerebellar circuitry, the easiest way to understand cerebellar circuitry is this. Okay, the cerebellar cortex itself, there is only one cell whose axon leaves the cerebellar cortex, and that cell is the Purkinje cell. So we can assume that the cerebellar cortex, only one cell leaves the cortex. So that is the only cell which has a direct influence on the rest. That is the deep cerebellar nuclei and the projections elsewhere. Okay, only one cell leaves the cerebellar cortex. One important point. Two types of connections actually enter the cerebellum. Okay, one of the fibers are called as climbing fibers. There is a 1:1 ratio between the climbing fiber and the Purkinje cell connection. Then there are fibers called as the mossy fibers. Through one example, we'll try to know what exactly is the role of this climbing fiber and what exactly is the role of the mossy fibers. There are a variety of other cells that are available within the cerebellar cortex, but they are all local circuit neurons, and they don't really leave the cerebellum. They are local circuit neurons. So of which there is the granule cell is one important circuit neuron which sends a lot of parallel fibers. So this mossy fiber inputs actually make connection to the granule cell, and the granule cell's parallel fibers make contact with the Purkinje cells. Whereas the climbing fibers make direct connections to the Purkinje cells. So just to summarize, Purkinje cells are the only cells whose axons leave the cerebellar cortex. Two types of fibers enter: climbing fibers and mossy fibers. Okay, so only two types of fibers. So what are these two types of fibers that enter the cerebellar cortex? Climbing fibers. The origin of the climbing fibers is the inferior olive. The mossy fibers have a variety of origins. I will go into little detail with respect to the vestibular system after having explained what exactly is the role for the climbing fiber and the mossy fiber. Okay, so when you see one particular, just one example of the vestibulo-ocular reflex, we know the semicircular canal is there. From the semicircular canal to the extraocular muscle is the vestibulo-ocular reflex. And this vestibulo-ocular reflex goes from the semicircular canal through the vestibular, through the vestibular nucleus. Abhishek?
Yes, sir.
See, make sure that there is no noise, okay, and other than the person who is presently speaking. Okay. Okay. Fine. Thank you. Yeah. So sorry for that brief interruption. Okay. So this is how it goes. It starts in the semicircular canal, goes to the vestibular nucleus, and then it goes to the ocular motor neuron, and from the ocular motor neuron to the eye muscle. This is the straight path. But then in addition to that, what exactly happens? I said that there is only one sensory system which actually has direct projections to the cerebellum, and that is the vestibular system. So this peripheral vestibular afferents actually send one input, okay, to the cerebellum, okay, to the cerebellum. One input goes into the cerebellum, okay. They can go directly to the cerebellum, or they can go after a relay in the vestibular nucleus. Then it will be called as secondary vestibular afferents. Otherwise, they are called as primary vestibular afferents. Both of them reach the cerebellum. Now, the first pathway for the vestibulo-ocular reflex was this one, but there is another pathway which actually influences the way this vestibulo-ocular reflex is working. Why should it be influenced? Now, it is not that whenever we make a head movement, we are always pursuing a target that is actually stationary. If the target is stationary, then the eye is moving in a direction opposite to the head movement, is a stabilizing movement. But what if you are watching a tennis match, okay, and you are doing a head and eye tracking? The head is moving in one direction. Eye also should pursue the same thing, which means in which case the vestibulo-ocular reflex has to be suppressed. What if you wear a new pair of goggles? I mean, new pair of spectacles. Then the vestibulo-ocular reflex gain should be adjusted. All these things should happen. So what will happen for that is that is where the cerebellar flocculus comes into play. Now here I was talking about two kinds of inputs that goes into the cerebellum. One kind of input is the climbing fiber, another is the mossy fiber. Okay, so they have two different functional roles. Okay, what am I attempting to do? What exactly is the attempt? That is told by this mossy fiber input. Here the semicircular canal is telling that I want to move the eye to compensate for the head movement. That is my attempt. So that input I am sending to the vestibular nucleus. From there it is going to the ocular motor. So what I am aiming, it sends one copy of that information to the cerebellum. That is the mossy fibers. What am I trying to do? Now, the other thing that the cerebellum needs to go is, okay, you are trying to do something, whether it is appropriate for the behavioral situation or not. If it is appropriate for that behavioral situation, whether you have actually succeeded in stabilizing gaze, that also the cerebellum needs to know. So that input comes here for this particular purpose of stabilizing eye movement. It comes through from the retina, the motion detector cells, accessory optic tract, from there to the inferior olive, and then from the inferior olive is the only source of climbing fiber inputs into the cerebellum. So this is what tells that whether you have achieved or not. If the VOR was appropriate, the gain was correct, behaviorally appropriate for that situation, what it should do, the vision of the object of interest should be stabilized on the fovea. If it has achieved that, then this will tell, yes, this gain is perfect. The cerebellum needs to do nothing. But then if it has led to a slippage or whatever, so the gain needs to be adjusted, then the Purkinje cell, which is the only cell whose fibers leave the cerebellar cortex, that will come and adjust the gain. So now I think this is clear. So there is one primary pathway, and then that pathway is influenced based on whether the aim has been achieved or not through the another pathway, that is through the cerebellum. So this comes through the inferior olive. So as far as the vestibular system is concerned, at least we can make some generalizations. The mossy fiber input, which is going up, is telling what am I trying to do. The vestibular system, it is trying to move the eyes. The climbing fibers are going to tell to what extent did I succeed in what I tried to do. Means, did I really stabilize the gaze or did I not stabilize the gaze? Okay. Based on the two inputs, then the Purkinje cell tells, okay, puts up this influence and then tries to make the correction. So this is the basis for the adaptation. Okay. So climbing fibers is the only source. The only source is the inferior olive. Okay. Now, other than just to make a summarization of a little more inputs about the what is going on information, that information. So here we see on to the cerebellum, okay, the mossy fiber input goes not just for the vestibular related drives or so many other drives, the eye position related drive, pursuit related drive, okay, saccadic movement related drive, all of those things are going to enter the cerebellum. Okay. And then of course from the inferior alloy, again this the information, the error signal, whatever is recorded at the retinal level, that is going to be reaching the cerebellum, and from there, from the cerebellum, there are going to be outputs. Okay, these outputs goes to the fastigial nucleus, interpositus nucleus, medial vestibular nucleus, and also to the, here we can see to the nucleus prepositus hypoglossal. So one is intent, another is the extent of success of that intent, that is the error information, and then finally all of them are put together and the adjustment signal is sent down from the cerebellum. So that is what it is done. The cerebellum is such a receptive organ, okay, unlike a lot of us human beings who talk more and listen less. This is a listening organ. So what I mean is 40 afferents enter the cerebellum for one efferent leaving the cerebellum. Okay, so that is the way in which the cerebellum is tuned. It is a receiving organ. It is always learning. It wants to learn. It wants to see what is going on, and then makes that small adjustment signal outwards. Okay. Now, the initial development of the cerebellum, vertebrate cerebellum, from the dorsal rim of the rhombencephalic clip took place in relation to the vestibular labyrinth. So that is why the cerebellum is considered to be so close to the vestibular labyrinth. Okay. Now, approach to classification of the cerebellar regions. Okay. We can't take the same approach to classification of cerebellar regions that we can take to the cerebrum. The cytoarchitecture in the cerebrum, when we saw so many areas, when we see the Broca's area, these so many areas have been classified based on the cytoarchitecture, whereas that kind of an approach is unhelpful in the cerebellum because the cytoarchitecture of the cerebellum is the same throughout. So cerebellar cortical regions cannot be functionally classified based on cytoarchitecture. So we either go by evolutionary growth, neuroanatomical connectivity, or both of them to actually make a functional classification of the regions of the cerebellum. Now, the archicerebellum is what is of interest to us. That is the flocculonodular lobe, which is closely associated with the vestibular system. The paleocerebellum or the anterior lobe, okay, mainly spinocerebellar inputs, recipient of the spinocerebellar inputs, and neocerebellum, okay, that is the inputs from the neocortex through the basal pontine nuclei. So from the neocortex is what it gets. So that way vestibular system is covered, spinal is covered, and also the neocortex is covered. Then projections to deep nuclei and vestibular nuclei, there is one more way in which you can look at the cerebellum. Okay, so lateral parts of the cerebellum project to the deep nuclei called the dentate nucleus. The intermediate part of the cerebellum project to the globose and emboliform nuclei, that is, they are called the interpost nuclei. The vermis, including the nodulus, actually projects to the fastigial nucleus. One more thing of interest that we need to know here is, okay, when we see this picture, the vermis, nodulus, flocculus, and paraflocculus, okay, the equivalent of paraflocculus in human beings is said to be the cerebellar tonsillar area, project to the vestibular nuclei, this part of the cortex. Now, lateral cerebellum, you saw, it goes to the dentate nucleus. Intermediate cerebellum goes to the interpost nucleus. The medial cerebellum, okay, including the, to a certain extent, the vermis and the nodulus, has a fastigial nucleus. Flocculus, paraflocculus directly projects to the vestibular nuclei. So it is also considered by some of the workers that the vestibular nuclei actually represent a deep nuclei of the cerebellum when it comes to the flocculus and paraflocculus region. Okay, they should also have a deep nucleus, and that counterpart, deep nucleus counterpart, just like how dentate is for lateral for the lateral part of the cerebellum, like that this is for the Okay, for each of the parts of the cerebellum, there is a deep nucleus counterpart. Like that, for the flocculus and paraflocculus, the deep nucleus counterpart can be considered to be the vestibular nuclei. Okay. Now, principally, when we talk about flocculus and paraflocculus, adaptation of the vestibulocular reflex is one of its function. It also has an inhibitory influence on anterior canal inputs. See, when it comes to maintaining the vertical gaze position in a straight ahead position, there are two competing inputs. The anterior canals trying to pull the eyes upwards, the posterior canal trying to pull the eyes downwards. For some reason, the anterior canal, okay, one of the reasons could be the more vertical orientation of the anterior canals compared to the posterior canals. This leads to the anterior canals giving primary activity from the periphery being a little more than the posterior canal, and therefore the anterior canals need to be under an inhibitory control by the cerebellum, and that ensures a balance. Okay, otherwise the eyes would not remain stable and they would drift upwards and lead to downbeating nystagmus. That primarily, if the afferent inputs from the semicircular canals themselves would lead to upward drift. To stop that, the cerebellum exerts an inhibitory influence on the anterior canal, and if that inhibitory influence is broken, that can lead to a downbeating nystagmus syndrome. Nodulus itself leads to prolongation of peripheral vestibular inputs. Okay, that leads to the contributing to velocity storage, and this applies not just for vestibular, it also applies for optokinetic, because the vestibular systems are mainly designed. Okay, the mechanical design is to be acceleration sensors rather than a velocity sensor, but acceleration means sudden head movement. The start and end of the head movement can be detected, but the ongoing head movement cannot be so well sent. That information cannot be sent from the periphery, but that has to be derived by the center. So that's deriving of the ongoing head velocity based on that the head has started to move now. Okay, this thing, like when you are sitting in a bus, you can make out that you have started the bus has begun when you feel a jerk backwards. When the bus stops, you can feel a jerk forwards. These two things you can detect by the jerk. That is how the cupula responds, with a jerk. But then in between, when there is a constant velocity, when the periphery is not good enough to take care of that, based on the memory of the previous jerk backwards, the velocity is concluded with the ongoing velocity is derived by the cerebellum. So for that the main thing is the nodulus. So with this introduction about the cerebellum, okay, and the basic relationship between the cerebellum and the vestibular system, I think I hand over this session now to Dr. Vijay Guge, who will be presenting two patients whom he had with vertigo, which responded to dalfampridine, that is 4-aminopyridine. So over to Dr. Guge. I'll stop sharing so that sir can start sharing. Dr. Guge, you can start sharing.
Thank you, sir.
Yes, sir.
My screen is visible?
Your screen is visible, sir.
Thank you very much, sir, for giving me the opportunity.
Yes,
Because of you, really I'm getting into vertigo, and it is a so vast and exhaustive field. We are knowing very little bit about it. I think we should try newer and newer things, whatever single reference or whatever rarer drugs which are useful in a vertigo management, because we have only 3 to 4 drugs which we are using in each and every patient of vertigo, and sometimes we are not getting the response. The dalfampridine in India, it was introduced around 1.5 years ago, and while reading about the vertigo, because of your regular channelization, I came to know this drug was introduced for the multiple sclerosis, basically by the name of Diagnostic by Pharma. So currently I am using it very vastly in vertigo patient, atypical vertigo patients, and we are getting very good results. So I am presenting to one very unusual case and one is usual case where we can use dalfenperidine. Dalfenperidine is basically 4-aminopyridine. There are two types of aminopyridine, 3,4-diaminopyridine and 4-aminopyridine. The 4-aminopyridine is basically has CNS penetration, and this is useful for the patients with central vertigo. So the first case is a 31-year-old male presented in December 2020 with 3 months
Hello,
history
sir,
of.
sir, sorry for interrupting. Are you moving the slides because we are not able to see the slides?
Yes, sir. I'm going to.
Sir, share the slides again, sir.
Share the slides again, sir, if you don't mind.
It is visible.
We can see the first. It is only seen is the dalfenperidine responsive vertigo.
Sir, now it's visible.
No, sir. Sir, you stop your sharing and then share it again, sir.
Okay.
Reshare, sir. Reshare.
And close this.
Now.
Yes.
Yeah, yes.
Yes, sir.
I just now it's changing.
Yes,
sir.
it is changing.
Yes,
It is
sir.
changing.
Okay, fine, sir. This is 31-year-old male presented in December 2020 with 3 months history of recurrent positional vertigo. First episode onset was sudden positional vertigo, mainly on turning in bed, predominantly on the left side. The vertigo lasted up to 5 to 7 minutes and associated with vomiting. Since it was a sudden onset, the another history about whether there was any possibility of stroke. So there was no associated history of slurred speech, dysphagia, diplopia, ataxia, or tinnitus or hearing loss. Patient did not have any history of migraine. Such recurrent vertigo, positional vertigo episode he is having for the 3 months before his presentation, and each episode lasts for 5 to 7 minutes, 2 to 3 episodes per day. He was started on number of anti-vertigo medications, but there was no response. And CT brain was done, that was normal. So we did the VNG of this patient, and whatever we find on right Dix-Hallpike test, there was predominantly a right beating nystagmus. Left Dix-Hallpike, there was a left beating nystagmus. On McClure-Pagnini test, on right McClure-Pagnini test, right supine lateral, there was a right beating nystagmus, and which was lasted almost 222 seconds. Left also it was lasted almost 4 to 5 minutes on left supine lateral. That means both the side, it is a geotropic type of nystagmus, which was lasted almost 4 minutes on each side. On each side, there was initial crescendo, but there was no much decrescendo after positioning to the either side. So this was the video. This is almost 9 minutes video. This was sit to supine position. That was right beating nystagmus first. Then right supine lateral. It was right beating. It was continuously beat almost 4 minutes. But there was no decrescendo. This is almost 4 minutes now. It is beating towards the right side. And it's geotropic variety. This is again right beating. And now it's like left supine lateral, left beating. There was initial crescendo, but there was no decrescendo pattern. The nystagmus is clearly visible, sir.
Yes, sir.
Either side in supine lateral, the nystagmus lasted almost 4 to 5 minutes. By definition, if any nystagmus lasts more than 4 minutes, we generally consider it as a probable central type of nystagmus. So here the patient is having geotropic nystagmus and not the apogeotropic, but it lasts prolonged period of time. So this VNG was done after 5 days of stopping all labyrinthine sedative. During the magnetic right turning turning to the left supine lateral, he had nausea and vomiting sensation. So diagnosis initially was made was probable left horizontal canal geotropic type of vertigo, and there was no response to any therapeutic maneuver. I tried both Goffoni, barbecue roll, force prolonged position, all failed. So whether it is a peripheral vertigo or it is really a central vertigo, because apogeotropic variety, we all know, we should suspect the central type of vertigo if apogeotropic nystagmus on macular Paganini test is there. But here the situation was different. Here patient is having geotropic type of nystagmus and not a apogeotropic type. So my big question, what to do next? Since the vertigo next lasted a prolonged period of time, I suspected the central type of vertigo, although it was a geotropic and no response to the any repositioning maneuver and anti-vertigo medication. So MRI brain was done, and this was the picture. He is having low-lying cerebellar tonsils. Low-lying cerebellar tonsils. So the diagnosis of a typical variety of central positioning nystagmus or central positioning vertigo was made. It is a very atypical case because patient is having geotropic type of nystagmus. So patient was started on 4-aminopyridine along with GABA agonist, that is gabapentin, 100 mg twice daily. Since December 2020, patient on 4-aminopyridine. For initially it was step up to 10 milligram of the BD and then gabapentin 100 milligram HS. Since last 13 months, he doesn't have any symptoms, and patient's follow-up VNG was absolutely normal and there was no nystagmus. So now patient is asking me how long treatment to be continued, because he already taking medications since last 13 months. And question against the rule, we know, is every geotropic bidirectional and bipositional horizontal nystagmus is surely peripheral, or sometimes it can be central? When to suspect central cause in geotropic horizontal canal BPPV? So this was the case, and patient beautifully responded to dalfenpyridine, and there was no nystagmus. But I am not aware how long we should continue the treatment, and since it is against the rule, patient is having geotropic nystagmus and prolonged period of time and vertigo. So when to suspect central type? I have suspected on the basis of the duration of the vertigo, because it was no decrescendo only. Continuously it was beating to either side in geotropic nystagmus. So I will go to second case. This is a usual case. First case was slightly unusual. This is a usual case where we can use dalfenpyridine. He is a 33-year-old male presented with sudden fall while playing cricket, and after getting up, he noticed imbalance, oscillopsia while walking. Since last 1 month, what he described as a vertigo. Also noticed imbalance after fast movement while head turning to the either side. Due to above symptoms, he was not able to play cricket, and there was no history of any migraine headache, no significant comorbidities, and no response to routine anti-vertigo medication since last 1 month. So on optokinetic, right to left and left to right, there was upbeating nystagmus in both the types. In optokinetic, top to bottom, there was again a horizontal nystagmus. Even bottom to top, there was again a horizontal nystagmus. That means both the type of vertical or horizontal optokinetic, both the types of nystagmus, both horizontal and vertical nystagmus were present. He had a downbeat type of nystagmus on removal of the fixation. Sorry, upbeat type of nystagmus. So he again is having on gaze test with fixation, left gaze evoke nystagmus. And on without fixation, he is again having upbeat nystagmus, gaze with gaze up, gaze down, gaze in the center. Everywhere there was upbeat component of the nystagmus was present. Even his smooth pursuit was impaired, slightly saccadic smooth pursuit. So central cause was suspected and MRI was advised. And the MRI is suggestive of ulnar cavity malformation. So if any patient with ulnar cavity malformation present, then we can use 4-aminopyridine. The patient is on 10 milligram of 4-aminopyridine once daily, and he is having more than 80% of improvement in last 3 to 4 months. He still is his VNG is suggestive of upbeating nystagmus, but clinically he is quite better. I had advised in any patients with trivial fall and patient is having imbalance or vertigo, always suspect CV junction anomaly or ulnar malformation type of things, and always advise MRI brain with CV junction. Thank you. Hello.
Yes, sir. Dr. Srini, are you available?
Thank you so much, Dr. Vijay.
Hello. I have finished both the cases, sir.
If Dr. Srini is not able to come online, and Dr. Vijay, it was a very nice, interesting patient. I have not come across geotropic having a central cause. Whatever we learned and then whatever we have seen is that geotropic having a peripheral only. But as you rightly mentioned, this patient has a continuous, no decrescento type of nystagmus that was continuing for nearly about 2 minutes. Am I right?
It's more than 4 minutes, sir. Either
More
side.
than 4 minutes. So that favors central. So you have a certain things combination of a peripheral and combination of central. And I was discussing with Shini where the central, where the peripheral ends exactly. Because when the nuclei is involved, when the nuclei to the connection is involved, central and peripheral always we play with this. That's different. But it's very nice, interesting documentation that you have done. And what about the other manifestations of anal carrier, or whether the person had any other features, or have you suggested surgical intervention? Do you have a thought process of doing a decompression and then doing the ENG later?
Right, sir. Basically, he doesn't have any gross ataxia. He was
Yes,
just feeling of mild oscillopsia and imbalance while walking.
Fine,
So
then.
I have tried this. Otherwise, if any patient is grossly ataxic, then definitely we have to go ahead with a decompression surgery.
Yes, sir. Yes, sir. Even if he surgery also, they won't accept for this
He was
issue.
just worried whether
such?
he will able to play a cricket or not. I have advised not to play cricket because if he have another fall, then definitely there will be difficult thing for him.
Fine.
Sir, Vijay sir.
Yes, sir.
Yes, sir. We are waiting for you, sir.
Sir, I just dropped out. There was a connection break,
Yeah,
so and then I rejoined. So cricket fall up the optokinetic up to there. I watched. I just want. Sorry for this. It is embarrassing to us. Was the second patient also having a Arnold Chiari?
Second patient is having ulnar carry, sir.
Okay, sir. Okay, sir. And first patient also had a
he is
tonsil.
having other features are not there, but he is having low-lying cerebellar tonsil, sir.
So low-lying cerebellar tonsils.
The beauty of this case is that he is having geotropic variety. That I have never. We are geotropic means definitely it's a peripheral, but here the vertigo lasted for prolonged period of time, sir.
Yes, sir. Yes, sir. So vertigo lasted for a prolonged period of time. We could see 13
vertigo
minutes.
5 to 7 minutes and nystagmus more than 4 minutes.
Sir, actually, I think at 4 minutes you got tired and stopped recording. Otherwise, it would have continued.
Yes, sir. Yes, sir. Yes, sir.
Okay. So the question is, Srini, that why geotropic? How to explain geotropic? Is that geotropic is sine qua non for peripheral, or can it happen central? That's a question that we have to take up, and then Dr. Vijay wants answer from you.
Sir, I think at least this lesson, these two cases simply tell that there is nothing like hard and fast rule. Okay, there is no hard and fast rule that geotropic and apogeotropic, and probably we are actually looking at. See, yesterday I was with Dr. Balamurugan. Okay, and there was a patient with, like, as long as the position was maintained, there was a ongoing nystagmus that used to go on and on and on. So probably there is one more concept that is coming up, that is like especially when you look at this congenital especially when we look at nystagmus in the blind people. Why do blind people develop nystagmus? Okay, they say that their primary vestibular influences, one of the explanations. Okay, I don't know whether with Dr. Pradeep Undavalli is there also. Okay, what happens is they need to be recalibrated. Okay, it is the availability of vision which allows the center to recalibrate the vestibular influences and make the eyes stable. Okay, and if so, basically the vestibular cerebellum or the cerebellum there is trying to do something called recalibration of the primary vestibular inputs. In the textbook definition, when we start reading textbooks, it looks like the amount of input that is coming from the right and the amount of input that is coming from the left is always equal. It need not be. We are always told that the weight of the cupula and the weight of the surrounding endolymph is same. We have been taught that way. What if that is not the truth? What if there is inherently, and which is more likely, inherently there is the cupula actually is not exactly the same weight as the surrounding endolymph? What if the cupula also is actually responding to gravity? Small amounts of tilts are happening. So there is a bias component. There is a bias component, and there is a in electrical circuitry and all, when we talk about a bias level, and there is a alternating current level. So there is a one DC level and there is a AC level above the DC level. That is what he said. So that DC level is considered the bias component. So whenever there is a turn of the head to one side, there may be a bias component, and there is a active head turning which will cause a over and above the bias component an additional level. Maybe the cerebellum is playing that role of actually controlling that bias component, keeping that bias component under control, and then only allowing the alternating component, the change, to be actually detected and put. And these are patients in whom probably that bias component, suppression of cerebellum of the bias component is not successful, or it has gone it has gone haywire, it is not able to work. And when we look at with that perspective, possibly we see apogeotropic more commonly than geotropic in central conditions, maybe because in the periphery, when we talk about the cupula being lighter or heavier than the surrounding endolymph, most of the time it could be that it goes in favor of a cupular dynamics working in such a way that it causes apogeotropic more often than the geotropic. That's all. Maybe just the statistics is such that more often it is lighter than being heavier, something like that. That is all. Otherwise, it is the cerebellar ability to control the bias component which is gone wrong. So anything that continues, anything that if you keep them in one position, or either to the right or to the left, and that is going on and on and on, okay, maybe we should start thinking in terms of the central conditions. Maybe Pratik is also listening. He may sometime he may jump on me because we keep having this discussion whether how many of the BPPVs that we see are really because of the particle. That may be a blasphemous statement, but then I had once gone to give a talk to a group of physicians in Kerala, and they are family practitioners, and they were never convinced about doing a positional maneuver at all. And they told me, we need to give a positional maneuver. We give one pill tablet, and most of them are okay after that. Why should I learn all these things? Because after that, patient is stable and patient is fine. Okay. Then when we come back and we see, probably there are a set of patients in whom it is a central abnormality. There are another set of patients in whom it is not a central abnormality. It's actually a particle. So it is a complete spectrum there. So maybe we should, at least these two lessons should tell us, these two cases should tell us that geotropic, apogeotropic is not something that we should be bothered about. It is the other characteristic like being prolonged, being in that position, and most important, not responding to therapy, having some other features. Okay, so these kind of things. And maybe we should not be chauvinistic about not asking for an MRI. We should start playing humble and begin asking for an MRI to complete the examination is my humble submission. Balamurugan sir. Sir, I think we are not able to hear you. Sir, you are muted, sir.
Yes, sir. I agree with you, sir. It's not one point that differentiate all are none like geotropic, apogeopatric. Like when you say neurology, there are certain features of UMN finding, there are certain features of element finding like that.
Yeah.
More and more. So over time that we may be able to say for which finding we should give more weightage.
Yes, sir.
In this case, the consistent or the persistent nystagmus for more than 4 minutes, 5 minutes continuing. So that is very unusual for a peripheral type of what we call the peripheral type. So that, and second, as he rightly said, that he has done the maneuver and then he has very clearly said that the person didn't, because who does the maneuver also makes a lot of difference.
Yes.
Can't say that because the person has not improved with the maneuver, but he has done the maneuver, he has tried all the maneuver, and then categorically would say that there is no improvement. These two things, I think we should give weightage.
Yes.
It's like rather than all or none law. But I think over years, when we start looking at these final points, yes, we may be able to say that how much sensitivity is specific for a given sign or a given particular thing.
Yes, sir.
I think that's a nice way of documenting. So geotropic, but having a central cause.
Yes, sir.
Treated that, and then that has disappeared.
Yes, sir.
When we start gathering this information, then we are the right people, because we will have more and more number of cases, and we are the right people to say that to which sign or which particular part of the VNG examination gives idea about central versus peripheral.
Yes. I think we are all learning, and more is coming. Sir, did you feel like asking Dr. Guge what made him think of dalfampridine?
Dr.
Guge?
Yes, sir.
See, I felt like asking you, okay, I was asking Dr. Balamurugan sir also. Sir, did you also feel like asking the same question? Like, what made you think of dalfampridine for this patient?
Sir, basically, we don't have anything. So, everywhere it is written in neurology books that aminopyridine is useful in downbeating nystagmus,
Okay.
unusual ataxias.
Okay.
So, you should use these drugs, because I don't have anything to offer to the patient. So, I use 4-aminopyridine in this patient, and he responded beautifully. Right now, I am having 10 to 15 patients on 4-aminopyridine, and everybody is doing very well. In fact, one patient, Dr. Shitish sir's, one patient is there from Delhi. He unilateral vestibulopathy. Patient is having unilateral typical vestibular neuritis, but persistent dizziness. 4-aminopyridine helpful in central compensation for those who are having persistent dizziness or persistent vertigo. So in that patient, we tried 4-aminopyridine, and she is almost 70-80% better. Intermittently, she is having increase in intensity of vertigo, but she is right now, she is able to do all her activity, and she was very much happy. Even I am having one more patient working with me only. He suddenly one day having imbalance while doing bath, and typically he's typical ataxic. So we did a MRI because we have to rule out the stroke, but he's having DNET in occipital lobe. So because we have started on anti-epileptic prophylactically, but he doesn't have any response. So in that patient, I started on dalfampyridine, and he is maintaining on dalfampyridine. He is very much happy. Whenever he missed the dose for 3-4 days, he again start feeling dizzy.
Okay. So now the other question, I think
central causes, parietal lesions or occipital lesions. I am having one patient. I have not documented thing, but one patient who responded beautifully to dalfenperidine, because all these parietal and occipital having connection with this vestibular thing, because
Okay.
vision is from occipital lobe and all the interconnection. So how it works, I don't know, or we have to search for it. But patient beautiful, definitely one should try 4-aminopyridine. But only one thing, everyone has to do ECG prior to giving 4-aminopyridine and calculate corrected QT interval. If it is prolonged, then you have to stop using the drug, and if it is not prolonged, then you can go up to 40 mg.
Okay, sir. Fine. So ECG is a must. Okay. In fact,
ECG is
I
a
was
must.
I was about to come to that. ECG
Yes,
is a
sir.
must, and we also read when we the moment we open up dalfenperidine, it is said that it is actually a drug which is used to induce seizures also in
Right.
animal experiments. So if it's a drug which is meant to induce seizures, now my question: see, you, Dr. Vijay, you are a neurologist. Okay, Dr. Balamurugan, he's a neurologist. Both of you have some kind of a license to give these drugs. Okay, we ENT surgeons, the moment we talk about giving this drug, we are a little hesitant. Okay, we don't go beyond the routine. Okay, 3 or 4 of the this thing. So, what is your advice for us beyond of doing an ECG? Beyond of doing an ECG, is there any other advice? Do you actually tell us, okay, please do it, or you want to tell us, just refer the patient to me, I will handle? Dr. Balamurugan.
Sir, any new drug, there will be some apprehension will be there.
Okay,
So
sir.
even the QT interval, if you take most of the anticanals, even for lacosamide, you take that, there is a chance of arrhythmias are there, lacosamide also.
Yes,
But started using now, okay, fine, there's no age, depending upon the age, other comorbid conditions, we started doing that. Any new drug, of course, we have to be careful till we get orientation, and then the number of cases are very, very rare, then we start using that. So like you start using that for all your vestibular paroxysm, you start using lacosamide, you start using that oxcarbazepine, this anticonvulsants, and then similarly, this is a potassium membrane stabilizing.
Okay.
That the way that we can start that. It's a new.
Yes.
We need some experience. Only one advice is that as it may induce seizure, and history of seizure also has to be specifically asked.
Yes, sir.
Can be very careful otherwise. So.
Okay.
I don't think it's a dangerous drug as of the protocol, then we see that, except the QT interval. So we need
So
more,
2 advisors here.
because
One
people
is
start using more
Yes,
this drug in the multiple sclerosis.
yes, sir. So 2 advisors. One is QT interval. Ask for seizure history. Yes, sir.
Yes, that's all.
Yeah,
So no
that's it.
need for evaluation for epilepsy. Seizure is there, then we can be careful.
Yes, sir. So the
And
next
it is
question is,
even- Yes, sir.
so the next question is, the moment, okay, we somehow make our minds and get the boldness to actually prescribe, how long do we go? And if you are giving prolonged, what is the monitoring we supposed to do? I think that is the same question Dr. Vijay Guge also raised. Like, how long do I go on giving? If at all we need to go on giving long, is there any specific monitoring that we need to do? Is there drug levels available for this or anything else?
I don't think that any drug level available. Dr. Vijay, are you aware of drug levels?
No drug levels.
Yeah.
No drug level. So how long can we
So
safely
I think
give?
we should follow the general rule 3, 6, 9, 12.
Okay.
And we can, neurology, we generally use 3 to 3, 6. These are the rule basically. 3 is a ideal. Epilepsy treatment 3 years. If you suspect epilepsy and if you are not sure, you can give 3 weeks or 3 months.
Okay.
It depends. So
Okay.
I think I prefer to give those who are having gross symptoms. I prefer to give, in this case, I have given for 1 year. Right now, I'm tapering gabapentin, and I will definitely going to taper his dalfenperidine. But once he had stopped the medications and he had a recurrence at that time. So
Okay.
I'm a bit worried whether to stop or not to stop.
Okay.
But in other cases, I am tapering it after 6 months of therapy.
Okay.
And I'm monitoring ECG every monthly.
Okay.
That is the things we are doing. But sir, I think you can explain the relative. This drug can be helpful to you.
Okay.
We can give 15 to 20 days and let's see the response. By
Okay.
giving for 15 to 20 days, there will not be any harm if you did ECG prior and calculated QTC.
Okay. So then the 3, 6, 9, 12. Can you explain that in a little more?
No, no, sir. These are the dictums.
No,
There
3,
is no
6,
rule
9,
because
12.
That's like-
most of the
It
What,
means
what
Dr.
years
Dr.
Vijay
are
Vijay is
saying,
trying to say,
sir,
it's like a
there
thumb
is
rule,
no
sir.
rule.
It's not hard and fast rule. It's a thumb rule. So
Sir,
for
the-
the
but-
Dynamo, you can use it for 3 months and then we can do that. So
Okay.
no reference. But what our professors say, that what Dr. Vijay is. Am I right to Dr. Vijay?
right, sir.
Yes, sir. So what our professor, no references for that, but thumb rule, like okay,
So 3 stands for 3 months, sir.
Yes, sir. Yes, sir. 3 months.
And if it is working in after 3 months, you continue for?
No. 3 months. If patient is having very good response, you can try to taper it off. And if patient is having recurrence, then you can continue. Then there is
Okay.
no rule.
Okay. So, but there is nothing like, okay. So if somebody needs it for, like now you have one patient who has completed 12 months.
Right, sir.
So maybe a year down the line, we'll have a patient
Sir,
for
in
whom you
this,
would have given for 2 years.
in this patient, why I am worried? Because he is having low line tonsil. That
Okay.
means pathology is always there.
Mhm.
Those patients who are having normal MRI, in such patient, I am trying to taper it off as early as possible. Otherwise, because they are having low-lying tonsil and Arnold cherry malformation, if I taper it off, definitely they will going to have symptoms. But still, I will try to taper it off after 6 to 12 months.
Okay, fine. So now, so far, the cases that you have used it for is for positional vertigo and positional nystagmus, and one patient of unilateral vestibulopathy who was not compensating. Is that right?
Sir, actually, almost 6 to 7 patients I have, 7 to 8 patients I did use it. All the central vertigos where I suspect this is typical central vertigo, although the MRI is normal, I always tried dolphin pyridine, and it has responded in many patients. Every patient is happy with the dolphin pyridine.
Okay. So I will just see some of the questions that are there in the chat box. I suddenly, because of an internet outage, I had to log out, so I could not see the questions before that. Okay, I think if I remember well, Dr. Oda was asking one question where, do you think that the motion sickness, whether motion sickness is actually because of can it be because of a nodulus dysfunction, cerebellar nodulus dysfunction? So what do you think, Dr. Balamurugan?
No ideas. No idea.
Okay.
Because
Dr. Vijay?
you have explained everything, you have to answer this question.
Dr. Vijay?
Sir, no answer, sir.
Okay. So we will keep that. Okay. Maybe we will explore that a little more with literature study. It is possible that it is not possible. We'll see that. Next. Dr. Saurabh Jain, any extra advantage over routine drugs used? Extra advantage, I think, because routine drugs were not helpful is why we went for this one. Okay, yeah. I think that
the failed routine drugs.
Failed routine drugs. So that means this has to have an advantage. Dr. Chetna Naik again asked the same question. How long do you give the drug? So the longest that you have given so far is 12. You are hesitant to stop 12 months. Stop that. So as we go on gaining experience.
In other word, what Dr. Vijay told us, we can infer that we can divide structural versus non-structural.
Structural versus non-structural.
Non-structural. If there's a structural cause,
yes, sir.
Then generally, because till you correct the structural cause, we are supposed to give that.
Yes. Okay.
There is non-structural, the functional, or only neurotransmitter problem, or the connectivity problem. Then we try for 3 months and then we can explain to them. If at all they are going to get in one more vertigo, they will come back. It is not like an where they have fall injury and mortalities are high, morbidities are high. So if they're going to get in again vertigo, they can come back and then we can start them. So the golden period of 3 months, if they had an advantage. That's the way that we can look it into that, though there is no definite guidelines at present.
Yes, sir. So structural cause till the structure is corrected. Otherwise, go by the 3, 6, 9, 12 rule and go on. And in any case, we have one person who has a 12 months experience. So even if we start from today, we will never have a patient who has who is beyond what you have seen. So we can always call you.
One question, sir.
Yes,
So
sir.
Vijay, at what dosage, Dr. Vijay, what dosage you started and what is the optimal dosage, or how many of the patients had a responded low dose or moderate dose?
Started with 10 mg,
Okay.
not gone beyond 20 mg. Patient
Yes.
is right now, all patients are maximum is 20 mg per day. 10 mg.
Any of your patient had any cardiac or rhythm disturbance, though QT interval was normal to start with? After that, any of them had any?
On BD dosage, no patient is having prolongation of QT interval till the time, sir.
Fantastic. Fine, sir.
Great.
Thank you, sir.
Yes, sir. So Dr. Ramesh Rohiwal is asking, I think this is directly to Dr. Vijay Guge. So it was the thyroid profile of the cases presented, Dr. Guge?
Sir, not did.
Not done. Okay. Dr. Preeti Mary is asking, what are the indications to give dalfampridine? In fact, based on that, I asked you the question, where all you had used. So you had used for these structural causes, and also wherever you thought it is a central cause, even though the MRI was normal. Is that right, sir?
Yes, sir.
Yeah. Dr. Lassia, can we give this drug in vestibular syndromes where MRI brain is normal? So that question is answered. So even though the MRI brain is normal, if as long as you felt that it was a central cause, you have given this drug. Okay. So I think with that, most of the questions from our from the delegates have been answered. If somebody wants to make a comment or directly ask a question to Dr. Balamurugan or Dr. Vijay, you can unmute yourself and please do that.
Sir, what about pediatric patients, sir?
Pediatric patients?
No pediatric patient yet.
Okay, sir.
Now, if at all there is a pediatric patient, now how safe is this drug in the pediatric patient? No. Okay.
Don't know.
I can see Dr. Balamurugan nodding, saying no.
No experience, sir. No experience.
Yes. So don't. Okay. No pediatric patients. Dr. Dhanya, can unresponsive migraine be in unresponsive migraine? Can dull step be used? Sir, would you give, sir, Balamurugan, sir?
When to call unresponsive migraine is one question, sir.
Okay.
Before it's a tough question when to call unresponsive. If you have tried all the drugs before for CGRP antibodies, monoclonal antibodies, if you want to try that, I think it's reasonable. But it's a good question, sir. Actually, I have not thought about that. After Dr. Dhanya has asked that, I think that why not before going for CGRP monoclonal antibodies, which are very costly. And we make a try, especially when they have a lot of vertiginous complaints. So we know that nearly when we ask a history that 50% of the people have vertiginous complaints, especially unresponsive migraine or refractory migraine or migraine. We are not able to give certain drugs because of the side effects of propranolol or other drugs. So in that situation, why can't we try? That's a good question that I think that I should take up this question. I can answer in the next meeting after trying that.
Definitely, sir. Definitely.
Thank you for the question.
Yes, sir. Any other question? I think Dr. Vijay must have had some issues with his internet or something. He's dropped out. Okay, we'll just wait for him to join. Anybody else has any questions? Dr. Devi Prasan has joined from Oman.
Yeah, I'm here at Oman.
Yes, sir. Okay, thank you for joining all the way from Oman.
Yes. Yes, sir. Thank you very much, sir. It was a very informative talk.
Yes, sir. Thank you, sir.
Can I ask a direct question, sir?
Yeah, please.
Can this drug be used for in pregnant ladies? Is it safe in pregnancy?
No.
Something has to be done.
I can see Dr. Balamurugan saying no, but I can't hear him.
So we don't have answer, sir. There's a new drug.
We don't have an answer. We don't have an answer.
Okay.
We don't have an answer.
Because usually what we see is when we see some apogeotropic nystagmus, we do that maneuver. We suspect it is a hyperlithiasis when it is a prolonged nystagmus. What we have been taught is when nystagmus does not end in case of hyperlithiasis, it continues for so many minutes.
Yeah.
That was what we had thought till now. But this is a very new information, sir. So all these cases we have to do an MRI, it seems. That is what I have.
Yeah.
Yeah. Yes,
We have to do an MRI is number one. Two is MRI may turn out to be normal, still it can be central is the second point.
Yes, sir. Yes.
Yes, sir. So MRI can turn out to be normal and still
Yeah,
it can be central.
Yes, sir.
So we had another thinking, right? If the MRI is turned normal, we used to correct the nutritional factors, right, sir?
Yeah, okay. Okay, thanks for bringing this up. Now I want to ask Dr. Balamurgan. Sir, how many times have you come across a situation where like everything turns out to be normal, but it turns out to be a deficiency of a certain nutrient? It could be B1, it could be B12, or it could be a micronutrient.
Yes, especially thiamine.
Thiamine, yes, sir. Yes.
That's the one thing that's commonly missed for a few reasons. So one is that I'm not talking about the alcoholic, because it's a thiamine deficiency is the first thing comes. Pregnancy, hyperemic gravidarum. So especially because they keep on vomiting, and then the same vomiting can happen in pyloric stenosis, can happen in some other GI disturbances, can produces this thiamine deficiency. And interestingly, the first nuclei affected, the first organ affected in thiamine deficiency is vestibular nuclei.
Yes, sir. Yes, sir.
They can have vertigo alone. So you're missing that component. And come with obvious ocular motor abnormality and then having ataxia. This is a case of thiamine deficiency, and go for an MRI showing that that's the late. Okay. If you start treatment, they respond. That's faculty. But pregnant lady coming, because that's my favorite area that I repeatedly telling my OG colleagues, if they vertigo, don't start this beta histine and all, give time. So there's some group of patients when they have the early manifestations of this Wernicke's only a vertigo.
Yes,
so now we have machine, we can document those cases, what type of nystagmus, ocular abnormality they have. That's a very interesting finding. I prescribe more thiamine, and I strongly say that when you're replacing thiamine, give good amount of thiamine, because most of the textbooks say that 100 mg of thiamine, which is not enough for thiamine deficiency. We have to give at least 800 mg of thiamine per day for at least 5 months.
Sir,
Yes, sir.
Sir, can you repeat that, sir? How many mg of day and what is the route?
I suspect thiamine deficiency. I suspect Wernicke's encephalopathy. I give 800 to 1000 milligram per day for 3 to 5 days in IV route.
IV route. Sir, you give it diluted in saline and then you give it?
Yes, I'm giving diluted in saline, but I have come across some of the reference giving a slow IV, but I'm comfortable in giving diluted in saline, giving over about 4 or 5 hours.
4 or 5 hours of 800 mg per day, and that is repeated over 4 or 5 days.
Yes, sir.
Great, sir. This is a really big information, because we used to give very little. Okay, as you said, we used to give only 100 mg.
There was an autopsy study from Australia.
Okay, sir.
Where they have studied all the head injury patients, they received thiamine.
Okay, sir.
It's sold the typical protocol thiamine of 100 mg. Any patient in coma, give thiamine 100 mg. Then you give dextrose. That's the protocol in any coma. So they have reviewed the case file, and then they have analyzed that those patients received thiamine 100 mg, but didn't autopsy because they died head injury. They found a lot of patients, of nearly about 40 to 50% of the patients had obvious evidence of Wernicke's encephalopathy, Wernicke's cause of psychosis, evidence in the autopsy of the brain.
Okay, sir.
They was the people, and they started telling that the thiamine that we are giving is not adequate. And British group studied, and then they said that we have to give a higher dose of thiamine for thiamine deficiency, and not the regular. That's probably for a preventive 100 mg.
Yes,
for
sir.
treatment aspect, you go for 800 to 1000 mg. And most of the newer textbook interested in on this type of nutrition deficiency, they started writing about 800 to 1000 mg per day for at least 3 to 5 days in IV routes.
Wonderful, sir. Wonderful. And oral has no role, especially when we are suspecting a deficiency state.
Yes, sir, because already they have a vomiting sensation.
Yes, sir.
The vomiting produces thiamine deficiency, or the thiamine deficiency causes vestibular problem, they will be having vomiting.
Okay, sir. Okay, sir.
So actually, Wernicke's first cases, historically, when you say that the first cases of thiamine deficiency documented in severe pyloric stenosis due to chemical burns in the stomach.
Okay, sir. Okay, sir.
So,
And hospitalization because of any GE upset, that also can precipitate a already low status of the thymine. Correct, sir?
yes, yes, sir. Yes, sir.
Yes, sir. Yes, sir.
And after this bariatric surgery also, renal failure, chemotherapy,
Okay, sir.
things contribute this thymine deficiency.
Great.
And Lasix, our furosemide.
Furosemide also. Okay, sir.
Yes, sir. Yes, sir. So these all the things.
Yes, sir. Sir, I think we are almost like 8:30 we began. It's 1 hour and 15 minutes. 9:50. I think this was a wonderful discussion. We learned a lot, starting from we started off with a new drug and another nutrient, how best to utilize the other nutrient. So I think at least people who have today attended this session have two things to take. One is dalfampridine, two is thymine. Okay, and who knows, a lot of those unresponsive vertigo patients may start responding to these newer things. So, is there any other question?
Sir, in the second case, gabapentin was added, right? Like, what was it meant for? Like, the second case? No, the first case. I mean, the first case, in the low-lying cerebellar tonsil, Dalstep was given, and also gabapentin was given.
Dr. Guge? Dr. Guge?
I think that what I understand from the presentation, if he is not there, what I understand from the person was already started on gabapentin. So he was trying to take out the gabapentin. That was the discussion he was telling them. With gabapentin, they added 4-aminopentine. And he was planning to take out the gabapentin. The reason for gabapentin, I don't know why they have started that gabapentin. Probably as a membrane stabilizer, they have given gabapentin. And gabapentin is for some of the neurology books started telling nystagmus gabapentin. No rationale for that.
Yes, sir.
And anybody has used this drug for episodic attacks? Any experience in this group, sir? Episodic ataxia type 2 or
anybody in the group who's there in the Zoom session who's used these drugs for episodic ataxia can share their experience, please.
Because that will be real interesting, because that's a classic channelopathy.
Yes, sir.
And this acting on the potassium channel, how they respond.
Yes, sir.
That's one thing that we can look.
Yes, sir.
We get information from those people who are treated this episodic ataxia.
Yes, sir. So if anybody has that, can unmute and please tell us. And one more experience, Dr. Shweta Shanai is there to share about thymine deficiency. I think she actually is talking from an experience of actually having seen a patient who is not at all alcoholic, but who's had a high metabolic state, that is a malignancy, and then that patient vestibular symptoms settled the moment she treated him with thymine. Dr. Shweta, are you there?
Yes, sir. He had downbeat nystagmus, which was not settling down. And this patient was on multiple medicines. So he had a hepatocellular carcinoma going on, which was highly metabolic. And along with that, because of psychosis, they had added antipsychotics. And the dynamics of that changed, like the pharmacodynamics of the antipsychotics caused worsening of the hepatic profile, worsening the thymine deficiency. So when we treated with 1000 thymine for 5 days, he recovered fully. So he never needed a psychiatric medicine in the first place.
Okay. So that's another beautiful thing.
And she gave 1000 milligrams. So it's not.
Yes. Because our gastro professor insisted on 1000 when he gave that.
I think the change has happened already. So people now started using not 100 mg, 800 mg. That's one thing that if you are treating as a deficiency, that's a nice point. Because of any high metabolic, that's a news, non-alcoholic high metabolic. That's a key word she used. Thank you, doctor.
So do we have to monitor magnesium when we give thiamine?
Yeah, that's another question. Magnesium and the potassium. So both
Okay.
be carefully mentioned, because they may go for when they have a hypomagnesemia, they may not respond. So that's a chance occurrence of hypomagnesemia. So we have to check the magnesium, and then hypomagnesemia may aggravate, they may not respond. That's the way that we have to look into that.
Okay. Thank you so much, sir.
Thank you, sir. And I don't know, Dr. Vijay Guge seems to have dropped out. I can see Priyanka Guge. Okay.
Yes, sir. Yes, I'm there.
Yeah, I don't know. So I don't know. Dr. Vijay Guge has.
Sir, actually, he's got some emergency, so he's gone. I mean, he left. Yeah.
Acute stroke care is
We
one
were
of his
still in the
interests.
clinic. It was a very, hectic day today.
Okay.
So yes, he's just made the presentation in half an hour or so.
Okay. So
Yeah.
thanks for joining.
Yes, sir.
And please convey our thanks to him. Okay.
Yes, sir. Sure, sir.
Yes, ma'am. Thank you. And thank you, Balamurugan sir, again for accepting this invitation. And
sir, I should thank you for being my teacher at the age of 50.
Not at all.
Wonderful teacher for the last 3 days, spending time with me. And I really enjoyed the inputs that you consistently giving for the past 3 days, and a lot of new learning for the past 3 days. I become more young last 3 days. Your teaching. Thank you, Dr. Srini, and more thanks to Dr. Vijay and the participants. Really, they throw more light on newer things. I think that's a very healthy discussion we had, and a lot of newer things. And the questions, certain things are not answered at this forum, and we have to take up those things, and then we have to keep answering. And
sir, one more permission. People may ask your number to clarify their doubts. Can
yes,
I share?
Sir.
Okay.
Yes, sir. Sure, sir. Thank you, sir.
Sure, sir. Thank you, sir. Thank you. And thank you again, sir. And thank you, Dr. Vijay. Thank you, Dr. Balamurugan. And thank you all the delegates, and thank you all the people for asking your questions. I hope your questions have been answered. If anybody has not, the question is not answered, even now you can just unmute yourself and you can ask. Yes, sir.
This question is for Dr. Bala, sir.
Yes, sir.
So what is the role of gabapentin in vertigo patients, sir?
No, I have no idea, sir. I have not tried that. And probably for nystagmus, people, all the textbook of neuro-ophthalmologist textbooks started telling that nystagmus, the drug for nystagmus is gabapentin. For that reason, whether they have been tried, I don't know, sir. Actually, the gabapentin high dose can produce vertigo. So that's the thing. Any anticonvulsants of a toxic dose, high dose can produce this. Yes, sir.
Yes.
Somebody is unmuting. Somebody wants to say something.
Sir, this is Dr. Vijay.
Yes, Dr. Vijay has come. I think your acute stroke care is over again.
Yes, sir.
Basically, it is a GABA inhibitory, GABA agonistic action. So it is a inhibitory response.
Okay.
So gabapentin is also useful in central downbeating type of nystagmus. So it was used along with dalfenperidine.
Okay, sir.
Okay. So he came to answer that question. Okay, I think Priyanka has just put his ear.
No, sir, just gone to see one urgent patient. That's why.
Okay. She called you in. Come and answer.
Thank you, Dr. Vijay.
Thank you for coming, sir. Thank you. Okay.
Yes, sir.
Okay.
Thank you so much.
Thank you all for this thing. So all of you being here, joining, thinking that on a Friday night, okay, made this session even more wonderful. Again, one more time I thank before this. If you're not subscribed to the Cyclops Learning Lab YouTube channel, please do subscribe to the Cyclops Learning Lab YouTube channel, because all this will be available there. So even if you miss out on this session, you can always catch up on the session later on. So with that, I again thank Dr. Vijay for bringing up his experience. I thank Dr. Balamurugan for the insights that he brought with his vast experience, the insights that he brought, and also the changes in therapy which this session is going to herald in the community. So thank you all, and thanks for joining. So with that, we conclude this session. Thanks to everyone.